Welcome. Dr. Sarah Jefferies is a public health physician in the Intelligence Group at the Institute of Environmental Science and Research, or ESR, specializing in national communicable disease surveillance and outbreak response. She's been providing public health medicine expertise on behalf of the Ministry of Health during New Zealand's COVID-19 response, including on national surveillance planning, risk assessment, and epidemic intelligence. She will discuss national outbreak epidemiology in New Zealand. Thanks, Sarah.
Tēnā koutou katoa, ko Sarah Jefferies, tōku ingoa, no Scotland ahau, ke ESR ahau e mahi ana, tēnā koutou katoa. Hello, my name is Sarah Jefferies. I'm a public health medicine specialist based here at the Institute of Environmental Science and Research Limited in Wellington. We've been supporting the New Zealand Ministry of Health with aspects of the national COVID-19 response. And we, as noted, provide national communicable disease surveillance, public health laboratory services and outbreak investigation support on behalf of the Ministry of Health. And today I'm going to give an overview of the epidemiology of COVID-19 in New Zealand to date, based on some of the surveillance systems that we manage here at ESR. Hopefully you can see the slide that I have shared. Please let me know if you don't have it. So in this talk, I'll be providing some background to New Zealand's COVID-19 surveillance response methodologies. Then I aim to present the major features of descriptive epidemiology in New Zealand, including the major person, place, time trends, identifying inequities where these exist, discussing the sources of infection, and providing an overview of the major outbreaks and features of clinical severity in New Zealand's case cohort, and considering these in the context of the global pandemic. So, on the 30th of January, the same day that the World Health Organization declared novel coronavirus a public health emergency of international concern, New Zealand made novel coronavirus capable of causing severe respiratory illness legally notifiable under the Health Act. And this meant that suspected cases of COVID-19 should be reported to a local medical officer of health. The criteria for defining suspected, probable and confirmed COVID-19 cases were set by the Ministry of Health with advice from a technical advisory group, and the development of molecular diagnostic testing for SARS-CoV-2 virus commenced in January through the coordinated efforts of the New Zealand Microbiology Network. Positive test results could then be directly electronically notified via EpiServe, the online notifiable diseases database managed by ESR, and case data collected was performed using the specific COVID-19 case report form, and a page from this form is shown here on the right of the screen. This national case questionnaire was developed and adjusted in alignment with the WHO reporting requirements and the surveillance priorities for the country. Other features of surveillance included in the response were the outbreak surveillance, which includes acute respiratory infection and COVID-19 outbreak reporting on EpiServe, syndromic surveillance, including severe acute respiratory infection surveillance in the Auckland region, and whole genome sequencing, which was undertaken by the National Virology and Sequencing Laboratories at ESR. I am focusing on notifiable disease case-based epidemiology in this talk, which we have been closely involved in, but I won't be touching on contact surveillance and broader aspects of COVID-19 in New Zealand, which will be covered elsewhere in this lecture series. So just a summary for those perhaps less familiar with New Zealand, that we are an ethnically diverse population of approximately 5 million people, with about 3/4 of the population living in the North Island, with the highest population density up here in the Auckland region. New Zealand has 20 district health boards served by 12 public health units, which operate under the Ministry of Health's guidance. I think it's really important at the outset to acknowledge the skill and hard work of New Zealand's public health professionals based in the ministry and public health units around the country during this pandemic response. They have a vital role in identifying and interviewing cases and their contacts, and developing and applying appropriate public health management. Of course, none of this would be possible without the essential work of the frontline and other healthcare staff, clinical laboratories, local communities, cases, their families and friends who've contributed to the New Zealand response. So this is New Zealand's national COVID-19 epidemic curve to the 19th of June for 1,507 confirmed and probable cases in New Zealand to that time. This shows the earliest date, that is the illness onset date or case detection date, if cases were asymptomatic, for example, for all cases in New Zealand to that time. Key aspects of the timeline of New Zealand's national non-pharmaceutical measures are shown by flags for border travel restrictions and shaded areas signifying the periods of the graded alert level-based interventions. And these interventions included progressive increases in social and physical distancing measures, school and educational facility closures, the details of which are summarised in the link on the slide at the bottom there. So New Zealand's response was characterised by a rapid escalation over a 10-day period to lockdown, with a peak of case presentations on the 23rd of March as New Zealand entered alert level 3 just before midnight, and cases then declined steadily through lockdown. Some major surveillance changes are noted in the timeline along the bottom. That includes the expansion of the COVID-19 case definition to include broader clinical presentations and epidemiological criteria, having initially been focused on more febrile acute respiratory infections, presentations and travel from affected areas. In general, confirmed cases were people who had COVID-19 confirmed by a laboratory test. Probable cases were close contacts of confirmed cases with clinically compatible presentations whose laboratory testing was inconclusive. National testing capacity significantly increased around March the 16th, from approximately 100 tests per day to approximately 1,000 a day. And by the 23rd of March, had approximately 2,000 tests per day being performed across New Zealand. A large increase in testing was then also seen with surveillance case definition expansion on the 1st of April to an average of over 4,000 tests a day. And there were two large peaks in testing associated with targeted testing surveys of asymptomatic and high-risk groups. That was on the weeks of the 16th of April and the 4th of May, with an average of over 5,000 and 6,000 tests taken a day. So New Zealand has had now among the highest rates of testing in the world. So this epidemic curve shows a geographic distribution of cases, with the colours representing the locations of cases across the 20 district health boards, and cases were detected throughout New Zealand in every DHB, and the geographic distribution is influenced very much by the sites where imported cases were most frequently detected and the sites where major outbreaks and most community transmission occurred. So on the chart, you can see a predominance of cases in pink. That's representing the southern DHB, the Auckland region in various shades of blue, and the Waikato in purple. So these were the areas with the highest incidence of detected disease. This table shows the age distribution of cases, with findings aligning with the international picture that COVID-19 is less frequently detected in children, which may be in part due to a tendency shown in several studies overseas towards children having milder clinical presentations and being less likely to be tested. You can also see from New Zealand data that higher incidence of disease was seen in females, young adults, and people living in areas of lower socioeconomic deprivation. So the lower deprivation is represented here by the New Zealand Deprivation Index quintiles represented there. These overall characteristics reflect the predominant characteristics of imported cases, which made up a substantial proportion of New Zealand's cases, except, however, for the female predominance. So the predominance of females shown here in the table is really a feature of the locally acquired cases and somewhat relates to the settings in which locally acquired outbreaks have occurred. This is New Zealand's epidemic curve by source of infection of the cases. So sources of infection were categorised into 4 groups based on whether cases could be epidemiologically linked to international travel or not. Case importation, which means infection which was likely acquired overseas, has been the largest contributing category by source of infection to the New Zealand epidemic so far, with approximately 38% of all cases having been imported. As expected, due to New Zealand's increasing travel restrictions, cases in returning travellers rapidly declined early in the lockdown from a peak of presentations on the 21st of March. Cases which emerged in the community with no known source were very few in New Zealand, and these are shown in the orange colour on the graph, approximately 6% of all cases. The demographic characteristics of cases varied by their source of infection. As noted, imported cases tended to be younger adults and they tended to be Europeans and of higher socioeconomic status. Locally acquired cases tended to cross the spectrum of socioeconomic backgrounds and showed female predominance with 63% of cases being female. In no group were Maori, New Zealand's Indigenous population, overrepresented in disease incidence among ethnic groups, and Maori tended to have the lowest incidence of disease among all categories of source of infection. This is a rare or good news statement for infectious diseases in New Zealand, with Maori often inequitably affected by infectious diseases and severe outcomes, including from previous pandemic experiences. To date, approximately half of New Zealand's cases have been linked to 34 outbreaks. Around 1/3 of New Zealand's cases were a part of 10 major outbreaks. I've overlaid these outbreaks on this graph, with the period of illness onset in the first to the last case for each outbreak represented by the span of vertical bars, and the size of the major settings, the size of the outbreaks in the major settings in which they've occurred are also shown here. The vast majority of outbreaks were initiated by transmission events occurring prior to lockdown. Most involved multiple regions, and the largest was associated with a wedding with epicentre in Southern District Health Board. The second largest was associated with a school in the Auckland region, and third with a hospitality venue in the Waikato, although the outbreaks usually extended outside of these settings, including into households. Although these outbreaks span multiple generations, due to lockdown and contact tracing, later cases tended to be confined to a household or other known contacts who were in quarantine. 6 of the top 10 largest outbreaks were not linked to imported cases, so were considered locally acquired. There was marked female predominance across all 10 outbreaks, but this was most marked in outbreaks involving institutional settings, schools, residential or aged care facilities, and this reflected the higher prevalence of females in these settings, both staff and residents. 4 of the top 10 largest outbreaks in New Zealand were associated with aged residential care facilities. Due to the serious association that aged residential care facility outbreaks have had with severe COVID-19 outcomes overseas, the Director General of Health commissioned reviews into the aged residential care outbreaks in New Zealand, and this review was recently published on the Ministry's website. Of the 22 COVID-19 related deaths reported in New Zealand to date, 73 have been in residents of aged residential care facilities. Household clusters are linked cases that are confined to a single household group, and over half of the cases in New Zealand have been part of household clusters. That's involving 323 households to date. This is expected given the public health measures in place during level 3 and level 4 lockdown. However, very few have been in cases under 15 years old, and only approximately 4% of cases have been involved in household outbreak, and only 5 of those cases have been identified as being the first case in a household. So this fits the international picture of the role of children in outbreak dynamics. A quick note on whole genome sequencing of the SARS-CoV-2 virus, and this is happening at ESR. The New Zealand viral sequences are being uploaded to a global open access database called GISAID, and that's to facilitate further scientific investigation. The genetic data is being integrated with epidemiological surveillance data to support our understanding of New Zealand's outbreak, and the diversity of global clades for SARS-CoV-2, which is seen globally, has been mostly reflected in what we've sequenced so far in New Zealand. So far we've sequenced 667 samples, and that's with thanks to funding from the Ministry of Health and MB. The majority of clades identified have been of European origin, and we're seeing a similar experience in terms of what Australia has seen in terms of sequenced isolates. This graph summarised symptoms reported for 1,503 cases. As noted internationally, febrile illness does not feature in the majority of clinical presentations of COVID-19, making 45% of the case cohort shown here. ILI presentations, which includes cough and fever, have also shown an even lower proportion of cases, just 33% of cases in New Zealand. The case definition focusing on fever and travel history early in the outbreak may have affected case ascertainment initially of this group, showing 51 cases were asymptomatic, with approximately half of them developing symptoms. The incidence of severe disease has been relatively low among New Zealand relative to other parts of the world. Certainly approximately 12% of Australian cases have been hospitalised. That compares with approximately 6% of New Zealand's cases. Cases who were hospitalised or died due to COVID-19 in New Zealand were more likely to be older, with significantly higher proportions of cases having severe disease outcomes among those age groups 50 years and older versus the younger age groups. This aligns with the international experience, as does a tendency for more severe disease outcomes to occur among cases with comorbidities. For 40% of cases with severe disease outcomes had at least one underlying condition. Severe outcomes were more frequently in cases reporting cardiovascular disease, including hypertension, diabetes, chronic neurological or neuromuscular diseases, renal failure and pregnancy than those who did not report these conditions. Please note though that this is an unadjusted odds ratio shown on the slide here, and it's not considered confounding by age, for example. Preliminary multivariate analysis indicates that age and certain comorbidities are likely to be independent risk factors for more severe clinical outcomes, however, and that fits with the international evidence. So there are updated graphics comparing international rates of COVID-19 and deaths on the New Zealand COVID-19 Public Health Dashboard, which can be found on ESR's COVID-19 response website. It also includes various summaries of national case and outbreak data presented in this talk, and that's updated daily. New Zealand's cumulative rate of deaths from COVID-19 has been among the lowest in the OECD, and similar to Australia, are approximately 0.4 cases per 100,000 people, which contrasts starkly to the UK, which has had among the highest rates in the OECD at 63 cases per 100,000 people. Countries with the lowest rates are shown in the palest blue colour here. But as we know, international mortality comparisons are affected by multiple factors, including testing rates, healthcare access, and population age structures, for example. So to briefly conclude, New Zealand's initial epidemic wave of COVID-19 has been characterised by low incidence and severity relative to the international experience. Imported cases arriving in New Zealand mostly prior to the lockdown, and locally acquired cases have tended overall to have had distinct demographic features, with more severe disease outcomes tending to be among the locally acquired cases and outbreaks. Household transmission has been associated with approximately half of New Zealand's cases, and the largest outbreaks to date have often involved institutional settings. And finally, with thanks to the multiple organisations and colleagues involved in the generation of these surveillance data and intelligence, some links to more information are also shown here on this slide, and I will leave it there for questions. Thank you.
Thank you, Sarah. We have one question that's come through so far, although I suspect there may be more as we continue. How did the patterns of cause differ, or how were they similar for children aged under 15 and for young people aged 15 to 24?
So how were the patterns of, was this causes in terms of source of infection?
Presumably, yeah.
So, so children didn't feature frequently in terms of imported cases. That was very much the younger adult age groups. Children tend to be infected more so in terms of the import-related cases and the locally acquired cases. However, the total number of children affected was quite low compared to the other age groups in the New Zealand cohort. So very much in terms of the major thrust of infection, it was focusing more towards the younger adults in the imported cases, and in terms of other groups, a range of demographics, but moving towards older age groups.
Thank you. And were there any hospitalized cases for people under 15 years? Do you have an age distribution for hospitalized cases, ICU, and death?
So there were certainly hospitalized cases in younger age groups. So certainly there was small numbers in the infants, and I think approximately 150 cases under the age 19 years of age. So a small proportion of the overall case cohort, so probably approximately 4% of cases that were hospitalised were in the childhood age group. In terms of the distribution of other ages, we've had the highest proportion of hospitalised cases were in the over 50-year age groups, with approximately 20% of those aged 50 to 64 in that hospitalised in that age group, and similar numbers for those in the older age groups.
Okay. Would you say that the number of cases would have been lower if borders had been closed earlier?
Well, there's a very obvious answer to that question. I mean, we've had 38% of New Zealand's cases were imported, and obviously the disease, the virus had to enter via the border. I think that the decision to restrict movement at the border has to be weighed against multiple factors, including negative impacts and indirect consequences of those decisions. So certainly we would have had more cases, but I don't think that there was an obvious decision to close any specific at any specific time before the sequential closures that did occur.
Okay. Here's an interesting one. Would you say that COVID-19 is a virus of lifestyle as opposed to one of general susceptibility? For example, those with cardiovascular issues probably smoked or had poorer diets or exercise regimes and therefore were more at risk of worse outcomes.
There are likely to be social determinants of poor disease outcomes in this infectious disease, as there are for multiple infectious diseases. The international evidence is suggesting that you'll have more severe outcomes associated if you are in older age groups and do happen to have comorbidities. So certainly it appears activities like smoking can increase your likelihood of having more severe disease outcomes, and so that's certainly a component of the picture of what we're seeing in New Zealand as well.
Okay. What was the distribution of the cohort in terms of ethnicity by age? Specifically, did Maori and Pacifica patients show differences in age compared to Paikea and non-Maori patients? The
numbers, so I don't have the specific numbers for that in front of me, unfortunately, but there was a fair general distribution in terms of the numbers of cases that were locally acquired that were Maori and Pacifica. Certainly the Pacifica cases that were locally acquired tended to be more adults, and that's very much relates to the demographic features of the picture of the outbreaks that tended to be locally acquired, with certainly staff often affected in some of the institutional settings, in particular in those age groups.
Okay. Our next question relates to contact tracing, and I know we'll be looking at that next week, Tuesday as well, but I'll ask you the question anyway. Can you share how contact tracing is done? And what is the average turnaround time for test results?
Right. So contact tracing is undertaken in New Zealand by public health units and by the Ministry of Health. So there's a national contact tracing service based at the Ministry of Health as well. And so essentially the aim of contact tracing is to, once a case has been identified, really quickly identify who the contacts of that case would have been while that that case was infectious in order to be able to apply public health interventions. So that involves a lot of work. It involves public health professionals interviewing the case to get a really good history of the people and the places that they had come into contact with during the period that they would have been infectious, and then subsequently following up with all of those different people that may have been exposed in those areas. So there's a great deal of teamwork and cooperation, both from people and in the community as well as with the public health professionals, to find all of these details and very quickly respond. In terms of the test turnaround time, I believe I probably can't speak to that because I don't have the most up-to-date times on that, but it is pretty quick. I know certainly at ESR, if a sample arrives, then you can get a test in the same day. So, but I'll perhaps leave more comments on that to James Usher when he's giving his talk later.
Thanks, Sarah. You briefly mentioned the existence of different clades of SARS coronavirus 2. To your knowledge, is there any evidence of differences in outcomes between them?
Not to my knowledge, but I am not up to date on the most up-to-date evidence in terms of that. That is certainly something that there are various research projects being undertaken in New Zealand to explore, and ESR is involved with one of those. So to see whether there is any clinical severity picture associated with particular clades is something that we are looking into and is of course of international interest.
Okay, now a fairly big one. What do you see in terms of the future for COVID and government responses or policies for mitigating future, arguably inevitable outbreaks?
The option for government policies to mitigate future potential outbreaks, I mean, there's a whole raft of international experience which is happening just now, and emerging evidence from the various diverse ways that countries are responding to this initial COVID-19 pandemic. There, of course, has been some initial success in terms of the incidence and severe disease outcomes relative to other countries in New Zealand with the current strategies that have been implemented, and that was a really fast and rapid gamut of various measures that were implemented. However, there's much to be seen in terms of what the flow and effects of these decisions will be, and the options for moving on from this position. And so I think there'll be a lot of evidence coming out from various countries which will inform the future decision making, but certainly we have got some interesting findings from our own experience today in New Zealand.
Okay, would you be able to comment on the differences in the duration of positivity of positive individuals?
So only so much as to say, so I'm not a virologist, but only so much as to say that there is certainly a wide range of positivity that has been reported in New Zealand and overseas in terms of the duration that we can detect RNA. So that's the genetic matter of the SARS-CoV-2 virus, which is detected through the nasal swab test. It's not necessarily though, however, that detection would represent having a living virus and the ability to transmit it as well. So there's more research that needs to go into that to see what exactly the meaning of this shedding is. But in general, shedding, you'll get a positive test, mostly detected within that first week of illness, with some ability to detect the virus often prior to that. And as we have demonstrated, you can also detect it in asymptomatic cases on occasion as well.
Thank you, Sarah. I think that's all we have time for today. It's now 1:30. I'd like to thank all our speakers and attendees for participating. The masterclass will continue tomorrow, 12 noon New Zealand time, and we hope to see you all then. Ngā mihi.